morning, everyone. Thank you for joining us. My name is Jennifer Gillick, and I am the Program Director for the Northwest Chapter of the American Parkinson's Disease Association, or APDA for short. We are so glad you could join us today for today's presentation about sleep and fatigue in Parkinson's disease. We'll be joined by Dr. Rebecca Gilbert, who is a movement disorders neurologist and is APDA's Chief Scientific Officer. Before we begin, I'd like to recognize the sponsors for today's program, Synovian and Kiowa Kirin. Thank you both so much for valuing these educational programs and for your financial support of APDA. We could not do these types of programs without you. I would also like to thank those of you who donated to our organization when you registered. We truly appreciate the support. And if you missed out on an opportunity to donate and are in a financial position to do so, we are in the middle of our year-end giving campaign and would appreciate your support. There is a link to our website in the chat section, so you can find that there. APDA is the largest grassroots network dedicated to fighting Parkinson's disease. At APDA, we strive to provide support, education, and research that will help everyone impacted by Parkinson's disease live life to the fullest. Our website offers an array of information, including educational articles, information about upcoming programs, exercise classes, and local community resources. You can visit our website at apdaparkinson.org/northwest or give us a call at 206-695-2905. And now for today's program. This program is being recorded and will later be posted on the APDA Northwest YouTube channel. I will also be sharing the slides from this program with you in a follow-up email. Dr. Gilbert's presentation was pre-recorded, and she will then join us here live to answer your questions. You can pose questions to any time to Dr. Gilbert during the presentation. You can type them into the Q&A box, which is located at the bottom of your screen. So now, without further ado, I present Rebecca Gilbert with Sleep and Fatigue in Parkinson's Disease.
Good afternoon, everyone. My name is Rebecca Gilbert, and I'm Chief Scientific Officer at American Parkinson's Disease Association. My talk now will be on sleep and fatigue, and I'll focus on both how to get a good night's rest with Parkinson's disease, and the flip side, how to feel more awake during the day with Parkinson's disease. These two are obviously related issues, but they are separate and related issues, so we'll try to touch on both of those. Here's the outline for my talk. First, we'll discuss why sleep is important to someone with PD, and we'll discuss why is sleep affected in someone with PD. And then we'll delve a little deeper into how sleep is impacted in PD, and we'll discuss 3 separate categories. 1, the sleep disorders that are associated with PD, the sleep disorders that result from PD medications, and then common PD symptoms that can impact sleep. The last part of the talk will focus on fatigue and excessive daytime sleepiness. These are 2 related but different non-motor symptoms in PD, and they are sort of the flip side of sleep, the wakefulness problems that can occur in PD. So let's start. Why is sleep important in PD? So it may be intuitively obvious to everyone listening that anyone who doesn't get a good night's sleep will have problems the next day. And in PD, these problems can be more pronounced than in someone in the general population. There can be worse motor symptoms. The actual PD movement problems can be worse. And then you can also have more difficulty in the non-motor symptoms. And that can manifest as worse cognition, for example. And then there is a pattern that sometimes is set up when you have poor sleep. And so that is one night you have poor sleep, you're very tired the next day. That leads to naps during the day. And then if you have naps during the day, you're not as tired as at night, and you have poor sleep at night. And you can get into this vicious cycle of poor sleep at night, tiredness during the day. And so that's something we want to try to avoid. And now, why is sleep affected in PD? So as you may be aware, The pathologic hallmark of Parkinson's disease is this element called the Lewy body. And that's this pink circle in the middle of this nerve cell, which is here in this slide in front of you. Now, Lewy bodies are abnormal accumulations of a protein called alpha-synuclein. And it's thought by many to be a key element responsible for nerve death in PD. Now, this is a picture of a dopaminergic nerve. And when Lewy bodies are present in these dopamine nerves, that is where you get the motor and movement problems of PD. But these Lewy bodies can be found really throughout the brain, in many, many areas of the brain, including areas of the brain responsible for sleep and wakefulness. And that is thought to be one of the reasons why sleep is affected in PD. So let's discuss some of the sleep disorders that can be associated with PD. The first, REM behavior sleep disorder, rapid eye movement behavior sleep disorder, insomnia, sleep fragmentation, restless leg syndrome, and sleep apnea. We'll go through each one of these and how they affect sleep in PD. Your physician, if you complain of sleep problems and your physician is curious as to maybe you have one of these sleep disorders associated with PD, may order what's called a sleep study or polysomnography. And this is a study that can be done either in a sleep center, and that would be a facility that you go to, you sleep the night in a bed that is supposed to simulate a bedroom. You're supposed to have a night's rest there. And while you're there, various bodily functions are recorded, including brain waves, oxygen levels in the blood, heart rate, breathing, eye movements, leg movements. This type of analysis can on occasion be done at home as well. And so that may be something you may want to ask your physician about. When all this information is gathered, it can be very informative about how a person's sleep is performing and whether that sleep can contribute to a restful night and a good restfulness the next day. So let's start with a discussion of one of the most common sleep disorders in PD, and that's the REM behavior sleep disorder, REM standing for rapid eye movement. To understand this disorder, we need to discuss the stages of sleep, which are depicted here in this graph. There are two basic types of sleep, rapid eye movement sleep, or REM sleep, and non-rapid eye movement sleep, and that's depicted here in these sections, N1, N2, and N3. You cycle through these types of sleep every approximately 1.5 hours throughout the night. REM sleep typically occurs for the first time about 90 minutes after falling asleep. And when this happens, your eyes move rapidly behind closed eyelids. And this is when dreaming occurs. Normally, people are paralyzed during REM sleep. And in REM behavior sleep disorder, a person is not paralyzed and can therefore act out his or her dreams. Now, the problem with this is it can cause injury to the person themselves. There are occasions when a person may, for example, throw themselves out of bed and cause injury, and it can certainly cause injury to the bed partner. And those are the two reasons why one would consider treating this disorder. Otherwise, the person who has REM behavior sleep disorder may not realize they have it. They may realize they're dreaming and they wake up and they don't realize that their dream has been so active, that they've been yelling out, that they've been thrashing. So in and of itself, it may not be problematic for the person with PD or the person with REM behavior sleep disorder unless they injure themselves or injure their bed partner. And so some of the treatments to consider, you may want to modify the sleep environment, and that may mean separate beds between bed partners, put mattresses on the floor to make sure someone can't throw themselves out of bed, bed rails, guard rails to protect the person, and that may be enough. If it's not enough, medications like melatonin and off-label clonazepam can be used to help to control the REM behavior sleep disorder. I must note here that REM behavior sleep disorder can be a part of what we call the premotor Parkinson's disease, which is a set of non-motor symptoms that can precede a diagnosis of Parkinson's disease itself, which means that it can precede any of the motor symptoms of Parkinson's disease. Other symptoms of premotor Parkinson's disease include poor smell, constipation, and depression. Now, just because you have REM behavior sleep disorder does not mean that you are going to develop PD. if you have it in isolation, but it is definitely something that is seen in retrospect. People with PD report REM behavior sleep disorder years before their diagnosis of PD. Now let's turn to another sleep disorder associated with PD, and that's insomnia. Primary insomnia refers to difficulty falling asleep at the start of the night. Secondary insomnia refers to difficulty falling asleep after waking up during the night, and both of these can be problematic in Parkinson's disease. Now, there are numerous medications that are on the market designed to induce sleep either in the beginning of the night or once you've fallen asleep. And these medications may be appropriate for those with primary or secondary insomnia associated with PD. However, medications that induce sleep can have unwanted side effects, such as gait instability or reduced mental clarity, and they can lead to sleepiness during the day the next day. So these medications do need to be chosen carefully, and there are other potential solutions that could be looked at and looked into first. And some of these are improving sleep hygiene. And so what that means is making sure that the environment, the sleep environment, is as receptive to sleep as possible. So you want to turn off screens. You don't want to be engaged in a phone or a device or an iPad right before sleep. That can really keep you awake in a profound way. You want to make your bedroom for sleep alone. You don't want to make it a hubbub of activity, of other activities. And you want to avoid specifically eating and exercising close to bedtime, because those can rev you up and keep you awake. Cognitive behavioral therapy can be helpful, try to induce sleep. You want to make sure that all your medications are reviewed. Medications for other conditions can keep a person awake more than they want. And so you want to make sure that those medications are reviewed. Depression and anxiety can also rev a person up in certain ways that keep them awake, perhaps mulling over ideas in the head before sleep, and that can be a problem. So treating depression and anxiety can be helpful as well. If none of these non-pharmacologic approaches are helpful, melatonin is a natural substance that the body produces that fluctuates during the 24-hour period and induces sleep. And that is a medication that can be given to enhance our body's own production of melatonin and can be very helpful in inducing sleep. If none of these work, then a sleep aid may be the next step, and a referral to a sleep specialist may be an appropriate step as well. Another problem that one sees in PD is something called sleep fragmentation. And this refers to brief arousals that occur during a period of sleep. And this can lead to poor sleep quality, decreased restfulness, and excessive daytime sleepiness, which we'll discuss later. The person themselves may not be aware that he or she is having arousals at all, and they may only be seen on a sleep study. And this is one of the reasons why a sleep study may be valuable. So here's an example of what sleep fragmentation might look like in a graph form. The top graph are young adults, and this is the normal cycle that we saw before, where REM sleep and non-REM sleep cycle about every 1.5 hours through the night. As we age normally, and in PD it's even worse, this cycle shortens dramatically, and there may be very frequent periods where a person wakes up in the night, so short that they're not aware that they're happening. And this can be very, very disruptive of sleep. You don't get a good stretch of good sleep, and this could lead to problems with restfulness. Let's turn now to restless leg syndrome. This refers to an uncomfortable sensation in the legs, sometimes in the arms, which is temporarily relieved by movement. It's often described by the person as either a crawling, electric, itching, or aching feeling, a very annoying sensation, making the person want to move. And it can occur in the evening and the night and can prevent or interrupt sleep. Now, what's very important to note is that restless leg syndrome can be an independent disorder, not associated with PD at all. So just because you have restless leg syndrome does not mean that PD is in your future, that they can be completely separate disorders. However, people with PD might have increased rates of restless leg syndrome. Restless leg syndrome can also be associated with damage to the nerves in the hands and feet, also known as peripheral neuropathy. and can be associated with iron deficiency. And so these two conditions should be investigated if somebody has restless leg syndrome, whether or not it's related to PD as well. Now, there have been no specific studies done for treatment of restless leg syndrome in PD specifically, but there are treatments for restless leg syndrome in general. And very interestingly, treatments for restless leg syndrome can be the same treatments that are used to treat Parkinson's disease. So despite the fact that many people who have restless leg syndrome will not become people who have PD, they are nevertheless treated with the medications that treat PD. So this implies that there is a link between these two conditions. So dopamine agonists can be used to treat restless leg syndrome with or without PD. Levodopa itself can be used to treat restless leg syndrome with or without PD, as well as medications such as gabapentin or pregabalin. And these are medications you can speak with your physician about if this is a problem for you. Let's turn now to another sleep disorder associated with PD, sleep apnea. This is a sleep disorder in which breathing stops and starts through the night. This breathing problem leads to periods of low oxygenation in the blood and frequent awakenings. Parkinson's disease may be associated with the two types of sleep apnea that are documented. One is called central sleep apnea, and this refers to a decreased drive to breathe during sleep, and it is due to brainstem lesions. As we already discussed, patients with Parkinson's disease can have Lewy bodies throughout their brainstem, causing many different kinds of symptoms, and this is one of those problems that can occur. There's another type of sleep apnea called obstructive sleep apnea, and this is due to the abnormal function of the muscles of the upper airway, causing blockages, therefore leading to decreased oxygenation during the night. Most commonly in the general population, this obstructive sleep apnea is due to sometimes obesity, extra tissue in the area of the upper airway, which causes the blockage, and sometimes weight loss is helpful for that. In Parkinson's disease, the obstructive sleep apnea is not due to excess tissue, but to an abnormal function in the muscles. Regardless, you can have a combination of obstructive sleep apnea and central sleep apnea in Parkinson's disease. The way this condition is diagnosed is via a sleep study. And what you would see are dips in the oxygen level throughout the night. And that would be the way to confirm that this is what's going on. The reason it's important to know whether or not you have sleep apnea specifically is because untreated sleep apnea, which means that you have dips in your oxygen levels in the night, can raise the risk of unrelated conditions like heart disease and stroke. It can cause depression, poor memory, and headaches. And so this is definitely a syndrome that, if suspected, a sleep study can really help many elements. So what are the treatments? So the first is simple. You want to elevate the head of the bed. Sometimes an oral appliance can help open the airway. And sometimes what's needed are devices that actually push air into the airway during the night. And these are called CPAP or BiPAP. These are non-invasive ventilation systems. So we just discussed a whole array of sleep disorders that can be associated with PD. We know that sometimes using a sleep study can help diagnose them. We discussed a little bit about treating each of them. Now let's move to a second category of sleep disorders that a person with PD may be grappling with, and these are sleep disorders that result from PD medications. And the two we'll be discussing are vivid dreams or nightmares. It's very common to get nightmares from dopaminergic Parkinson medications. These can be just simply very vivid dreams. They may not be upsetting at all. They can be very upsetting and cause a person to wake up upset, and that can interfere with sleep. A simple solution sometimes is just moving that last dose of Parkinson medication to earlier in the day, and that could solve the problem. Another problem that can occur with Parkinson's disease medications is something called sleep attacks, which is falling asleep without warning, falling asleep without any sign that you were tired. This can be very problematic doing something like driving. So there's no warning that you're tired and so you shouldn't be driving, and nevertheless you fall asleep. This can be a problem specifically with dopamine agonist medications, and it's definitely something to think about before the medication is started. The third type of sleep problems that can affect somebody with PD are when a symptom of Parkinson's disease interferes in sleep. So as you are aware, Parkinson's disease symptoms are divided into the motor symptoms, and these are the symptoms that affect movement. These are tremor, slowness, stiffness, and balance problems or postural instability. And these we typically think of as the symptoms of the iceberg that can be seen above the water. These are symptoms that can be seen, they're visual. However, there are many non-motor symptoms, and these are represented as a big part of the iceberg beneath the water, a very problematic part of the iceberg, yet not seen. And these are the symptoms that do not affect movement. There are a number of Parkinson's disease symptoms, both motor and non-motor, that can affect sleep. And I've highlighted these in yellow. So the motor symptoms that can affect sleep, tremor and stiffness. So people may wake up with tremor, they may wake up with a sense of rigidity that impedes their ability to go back to sleep. The non-motor symptoms that may affect sleep, anxiety, hallucinations, pain, and urinary problems. And we'll discuss each of these in turn. Anxiety. So anxiety refers to worrisome thoughts, and these can keep a person from falling asleep both at the start of the night or from falling back asleep upon awakening during the night. Now, everyone has experienced this at some point in a very stressful part of their life. They may ruminate or play certain thoughts over again and again, and people with Parkinson's may have this as a more persistent problem. So this is certainly something that I hear a lot about, interrupting sleep and invading sleep. So what are the treatment options? One are lifestyle modifications. Exercise, meditation during the day may help to quell some of those thoughts before bed and at night. Cognitive behavioral therapy is definitely something to consider. Try to find more useful ways of dealing with those ruminating thoughts. And if those don't work, medications, SSRIs, selective serotonin reuptake inhibitors, or SNRIs, may be helpful to help these thoughts. And again, we don't have enough data to recommend a specific one of these SSRIs or SNRIs for anxiety and PD. This is a topic that requires much more research that has not yet been done, but certainly anecdotally we know that these medications can be helpful, and it's something to discuss with your physician. Hallucinations. Hallucinations are very common in PD, and they're typically a side effect of our dopaminergic medications, which can all cause hallucinations. Hallucinations can also be part and parcel of Parkinson's disease itself, and so both of those should be considered as the cause of potential cause of hallucinations. Common hallucinations in Parkinson's disease: furry animals, babies, cute, cuddly animals, sometimes dead relatives. And sometimes these images are pleasant. Sometimes the person is aware of that these are hallucinations and they're not bothered by them. But sometimes hallucinations can be very upsetting and can be very disturbing. And a person may wake up to a hallucination and then find it very difficult to return to sleep. And so dealing with hallucinations can be one way to help improve sleep. And there are strategies to help improve hallucinations. One would be to adjust Parkinson's disease medications. And if that's not effective, there are medications available to try to quell hallucinations. Urinary symptoms. So urinary symptoms are extremely common in Parkinson's disease, and they can certainly interrupt sleep. They can interrupt sleep for many older adults with or without Parkinson's disease. And these symptoms include urinary urgency, a real sense that you need to get to the bathroom immediately, frequency, you need to go to the bathroom a lot, and nocturia, simply having to go to sleep specifically, having to go to the bathroom, specifically at night a lot. Sometimes there's frank incontinence, where urination happens without your control. So to treat this problem, certainly you want to be assessed for other causes of urinary issues. For example, an enlarged prostate is a very common cause of urinary problems in the general population, general male population, and can also be a problem for Parkinson's disease patients too, and that should be investigated. Now, urinary issues of Parkinson's disease can be treated with medications, but some of the most common medications used for urinary symptoms in the general population can have cognitive side effects. And so you want to be careful with your urologist about which medication to choose. And sometimes that requires a conversation between the urologist and the neurologist. And finally, botulinum toxin injections could be considered. And this is of the bladder, and this is a way to relax the bladder and not have the bladder so tense, wanting that urine to be forced out so frequently. And now let's discuss how motor symptoms may impact sleep. Motor symptoms such as tremor and stiffness can impact sleep. Now, as you know, the symptoms of Parkinson's disease can fluctuate throughout the day, depending on the time from the last dose of medication. So typically a person takes a dose of medication and experiences a clinical improvement. And then over time, there may be a return of those symptoms. So what may happen at night is a person takes their last dose of medication before bed, the medication is effective, they're able to go to sleep, but over the course of the night, the medication wears off and the symptoms of Parkinson's return. They wake up for whatever reason in the middle of the night, and their Parkinson's motor symptoms have returned with tremor and stiffness, and they find it hard to go back to sleep. So how to address this problem? Here is a table of some of the levodopa formulations that are available that can be used to treat Parkinson's disease motor symptoms. The top line is the standard formulation of carbidopa-levodopa. This is the immediate release medication, also referred to as Sinemet. But there are other medications available that may provide more continuous drug delivery. And these may be options for people who need a bit longer, having that on time a little bit longer through the night, so that when they wake up, they don't have those symptoms right away. And so there is a carbidopa-levodopa extended release, or ER, which is generic only. And then there are extended release capsules, also known as Rytary. And this could be a potential option to take right before bed to see if that gives a little bit of extra help through the night. And finally, there is an intestinal gel, which currently on formulary is meant to be shut off for the night, but that is something to be talked about with your doctor if the motor problems at night are interfering with sleep. So now what we're going to do is turn to the flip side of trouble sleeping. And that is talking about trouble with level of alertness or maintaining wakefulness during the day. We'll discuss two related but distinct symptoms, fatigue and excessive daytime sleepiness, or EDS. Let's start with fatigue. Now, many people with PD describe fatigue as more encompassing than simply being tired. They'll use words such as I'm run down, I'm out of energy. Some will report that sleep is not refreshing and does not relieve the fatigue that they're experiencing. Now, there are many reasons why fatigue might be occurring. The first, of course, is poor sleep. We have just spent the last approximately half an hour discussing why sleep can be poor in Parkinson's disease, and there are many, many reasons. It could be poor sleep hygiene. It could be a PD sleep-related disorder. It could be a sleep disorder from PD medications. It could be a PD symptom that interrupts sleep, etc. And all these things can produce a poor sleep night, which can lead to fatigue during the day. And remember, there are some sleep disorders, such as sleep fragmentation, in which the person themselves may think they're getting a really good uninterrupted sleep, but they're not. And so all these need to be evaluated and considered to try to help the fatigue during the day. Another possibility is that we're dealing with a medication side effect. So Parkinson's disease medications can cause someone to feel tired, as well as other medications that a person may be on. Polypharmacy, where many medications are taken together for various medical problems, may compound the problem. So reviewing medications can be very helpful as well. There may be a related medical issue which is causing fatigue, such as hypothyroidism or thyroid imbalance or anemia. And these things should be evaluated for as well with the complaint of fatigue. Depression. We discussed earlier that sometimes depression in the form of anxiety can rev a person up, but on the flip side, depression can also make a person feel just really low and without energy. That should be evaluated for as well in the setting of fatigue. But it could be that a person has a sleep study that does not reveal a problem. There's no medication that can be blamed. There's no medical issue that can be blamed, and there's no depression that can be blamed. And still the person has this unrelenting fatigue. And we hear this from our patients. And so this is something we do not fully understand, but it may be due to neurodegeneration or Lewy bodies in areas of the brain that maintain wakefulness. So it could be its own non-motor symptom that needs to be dealt with separately from the problems that we have discussed up till now. Now let's turn our attention to another problem that's common, which is excessive daytime sleepiness. So fatigue refers to this overwhelming sense of feeling tired. Excessive daytime sleepiness is the inability to actually stay awake during the day. And people report, care partners report that a person with PD may fall asleep for large chunks of the day and not be able to maintain that wakefulness. So both fatigue and excessive daytime sleepiness are similar, kind of a similar set of causes that need to be considered. And we just went through all those causes on the previous slide. And if any of those causes are revealed, treatment can be directed to it. And so, of course, a sleep disorder at night or medication side effects, depression, they can all lead to both fatigue and excessive daytime sleepiness and need to be evaluated to really fully understand the picture. What I should mention is that excessive daytime sleepiness increases in prevalence as PD advances. So this is a symptom that can be seen more frequently as Parkinson's disease becomes more advanced. And so what are some strategies that improve wakefulness during the day? So if the problem can't be solved with improving sleep at night, are there ways to improve wakefulness during the day nevertheless? And there are. One is to encourage daily exercise and activities. A person without activity is more likely to doze off than a person who has activities engaged throughout the day. You want to be realistic about scheduling a person, especially if the person has advancing PD, but aiming for at least one scheduled activity a day can be very helpful to people who are battling this excessive sleepiness. Of course, COVID has really been a problem in this arena in getting people more active. It's limited how much a person can do during the day, and that is something that we hope we see an end to as soon as possible, and I'm sure everyone will agree with me on that. Another non-pharmacologic intervention that's gaining some momentum is light therapy. Light therapy is a therapy in which a person is exposed to bright light via a light box. It's been used as a treatment modality for various sleep disorders and psychiatric syndromes that are not associated with PD. And there have been even a small clinical trial testing its efficacy in PD, and it demonstrated an improvement in both sleep and excessive daytime sleepiness. So this may be something you might hear about a little bit more in the future. There are no FDA-approved medications for excessive daytime sleepiness or fatigue in the context of PD. However, clinicians sometimes prescribe medications off-label for this very problematic problem. These medications may include modafinil, methylphenidate, caffeine, and there is some success with these medicines. Of course, there are side effects as well, so please discuss these medications with your physician. And there is a new medicine on the market, relatively new medicine, called istradefylline, and it's a medication currently approved for treatment of motor symptoms of PD. But a small trial recently was done to demonstrate its potential benefit for excessive daytime sleepiness as well. So perhaps talk with your physician about the possibility of using that medication as well. So to summarize what we have discussed today, we have looked at the various sleep disorders that can affect a person with PD. So the sleep disorders directly associated with PD, sleep disorders that may result from PD medications, common PD symptoms that impact sleep. And then we looked a little bit about the flip side of sleep, wakefulness. We looked at 2 non-motor symptoms of PD, fatigue and excessive daytime sleepiness, and discussed a little about why they may happen and what potentially we can do about them. So on that note, I'd like to thank you very much for your attention. I hope you gained a little bit more insight into your sleep and wakefulness issues in PD. And please feel free to contact me at rgilbert@apdaparkinson.org if you have any questions. Thank you so much.
Where'd it go? Hello, everyone. Oh, I can see, you can see me. That's good. I would like to now introduce Dr. Rebecca Gilbert live. She is going to pop on the screen, we think. All this great technicalities here.
Hi, I'm here.
You are
and
here, good.
I'm clicking start video and it's telling me that my host has stopped it.
Okay, well, let's figure this out. Why does it say, start I didn't stop anything. All right, well,
We can just talk like this. That's
well,
fine.
we can talk, and in the background, Jean is our host, so she has complete control. So she's going to try to figure out how to get your video to turn on. And for now, we'll just talk this way, and you will be on the sound. And everybody, I'm so sorry, has to look at me.
No.
So for now, so I want to start the first question. I had a lot of questions about, oh, hey, there you are.
Oh,
She made
here
you
I
host.
am.
Awesome. Good job, Jean. Good thinking. Hello.
Hello, how are you?
I'm great. I'm great now that I can see you even better. So I'm going to start the question and answer. Well, first of all, let me give some instructions to folks. We're going to try the Q&A one of 2 ways. You can type your questions into the Q&A box, or you can raise your virtual hand and I'm going to let you talk. So it'll be like a radio call-in show. So for everybody, for your questions, please try to keep your questions general in nature and brief so that we can get to as many questions as we can. So either type it in or raise your virtual hand, and you can find both of those options within the bottom part of your screen. So the first question I have is about melatonin. We had a lot of questions about that come in before you started talking, and then a couple more have come in. So we'll start with, when's the best time to take melatonin, and can it be taken before and during sleep?
Right. So this is a great question, and I feel like there's an incredible amount of confusion among physicians about best practice. If you speak to sleep disorder physicians, they will generally tell you that you need to take your melatonin a couple of hours before you want to sleep. And that's because you want the rise of the melatonin that you're taking by mouth to jive with the increase that's going to happen naturally as you get ready for bed. And so, taking it right before bed is not the answer. So you'll see different people say 30 minutes, 60 minutes, but I think typically the sleep people who know their sleep medicine will say about 2 hours before. This is something people can try. They can try 2 hours before, they can try 1 hour before and see how it helps them. And there can be some variability among people. So that's something to keep in mind as well. Another thing that you have a lot of variability about among different physicians is how much to take. You'll definitely have sleep physicians that say less is more, take 1 milligram, don't take 10. And so there again, but you'll have a lot of different recommendations across the board. So sort of, if you're new to melatonin, I'd go with 1 milligram 2 hours before, see how that works for you, and then go from there.
Then the other question I have that I've heard differing things about is that not all melatonin is created equal, that there's been a lot of testing of melatonin, and so you kind of have to be careful about which kinds you get. What's your knowledge of that?
Right, it is not extensive. I mean, I know that melatonin, as everyone knows, can be purchased in a pharmacy without a prescription. They're over-the-counter versions, and there are many, many manufacturers. I would not stake any claim to say this manufacturer is a good one, and this is a one that you should pursue. And so again, I think it's going to be a matter of trying one. You could potentially ask your physician for a prescription for it and then get one that potentially, and again, I'm not 100% sure that would be the case either, but potentially may be more regulated if you get one by a prescription.
Okay, great. So to stay kind of on this, I guess, medication subject, a couple of people were like, melatonin doesn't work. What are the other options besides melatonin? I've had a couple of questions about the use of Tylenol PM as a sleep aid, and some concerns about dementia with that sleep aid. So can you address that a little bit?
Yeah, these are all amazing questions. So I just want to preface, generally, the use of medications for inducing sleep, at which I said in the presentation, is a double-edged sword. And anyone who's taken a sleep aid will know this, because it makes you sleepy. And so it needs to make you sleepy exactly when you want to be sleepy. And if you wake up to go to the bathroom, you don't want to be sleepy then because you don't want to fall. That's really hard. That's a lot to ask from a medication, that you take it and puts you to sleep, and then you wake up to go to the bathroom. You're going to be wide awake to get to the bathroom so you don't fall. Then you're going to get back in bed. You're going to be sleepy again. Then the next morning, you're going to feel wide awake. It really hardly ever works that way. And so you have to be prepared to be groggy and sleepy and maybe not as clear in the mind and maybe a little bit more unstable once you've taken these medicines. So you really want to be careful. Having said that, many people, all the different sort of non-pharmacologic ways of inducing sleep are just not helpful. They turn the lights down. They don't use any of their screens. They got their cognitive behavioral therapy. They do their best. They have their warm milk. They have their melatonin. Melatonin is actually a better choice in terms of those side effects. It has a better side effect profile, although, obviously everyone can be affected differently. But they've tried all that stuff, and still they just can't sleep. And what do you do? And so, many people with Parkinson's are taking sleep medications. That's the reality. So, what do you do? It is true that some of these over-the-counter sleep medications, so let's say a Tylenol PM, will have an antihistamine in them, or will have medications that are pretty mild and benign for the general population and will induce sleepiness and can be really good options for the general population, but can make somebody a little more groggy or a little more confused if they already have cognitive problems. So again, this is part of the side effect profile that you have to be concerned about. And every medicine, even the over-the-counter ones, have to be treated with caution and certainly in discussion with your doctor. Having said that, if you have some mild cognitive issues and you also have insomnia, your doctor may be okay with you taking Tylenol PM, but definitely to talk to your doctor about any of these options, especially a medication that can induce sleep, even if it is an over-the-counter medication. Did I answer all the, oh yes, I think another part to this was what prescription medications can be used. And so there are a bunch of different mechanisms of action. There are melatonin receptor agonists. There are a bunch of those. You may have seen commercials, Roserum and Lunesta and medicines like that. And those are medicines that some people find to be helpful. And then there's Ambien, which is a medication that's similar to a class of medications we call benzodiazepines, which I'll get to in a second. And it's a milder medicine, and it is used. It does have a long-acting version, which sometimes can be helpful, which I know there's a bunch of questions on, that secondary insomnia piece. So they're fine going to sleep, and then they wake up for some reason and can't go back to sleep. So sometimes a long-acting sleep medicine like Ambien CR is something to consider for that. But then again, the flip side is that a longer acting medicine will last longer and will have the grogginess longer. So again, everything has to be balanced. The sort of most sleep inducing sort of worrisome group are this group called benzodiazepines, and that group is Ativan and clonazepam. Those are medicines that we do try to avoid. Many people with Parkinson's are on them. So if if you're one of the listeners and is on the medicine, obviously your doctor has thought about all the side effects and has decided this is a medicine that isn't good for you. But we certainly give it a lot of thought before we prescribe it because of the potential for side effects in that group.
Okay. How about CBD?
Right. So the concept of medical marijuana in general, I actually have an entire talk on medical marijuana, and we can do the Take Control series with that one next.
Sounds like a good one.
Because really this topic does need about a half an hour. But quick and dirty, CBD is as a chemical extracted from the cannabis plant, and it has a wide range of potential effects in the body, and one can be inducing sleep. There hasn't been a study that looked at CBD and PD and insomnia, but anecdotally, certainly people say that it is can be beneficial. I don't know what the status is in Washington State or the states that APDA Northwest covers in terms of how you get access to CBD. It's very variable across the country, but definitely it's not an unreasonable option for people who have, are need an actual pharmaceutical. And the only thing I would say is it is a pharmaceutical, exactly like a benzodiazepine or exactly like an Ambien or any medicine that you're considering for sleep. You have to think exactly along the same lines about CBD. What are the side effects? It's going to cause the grogginess, it's going to cause difficulty with balance. How is it going to affect you? How is it going to affect your ability to take other medicines, etc.? And when it's viewed through that lens, it becomes another sleep-inducing medicine that you have to really consider and take in all the the different pros and cons. But definitely something to bring up with your doctor.
Sure, great. And I know that you did a blog on CBD as well.
Yes.
Yeah, so that's a good read for those of you who haven't read the Dr. Gilbert host's blog. Or no, it's not it's her blog. It's up there. I'm getting all the things you're doing mixed up. So yes. So thank you. Great. So off the medication thing for right now, what about tips for rolling over in bed?
So that's a great question. So part of the issues about sleep can be this, your motor symptoms return and you're stiff and you're just uncomfortable and you just can't get comfortable to go to sleep, or you wake up and you're very uncomfortable. So what I have heard from patients is using silk sheets or silk pajamas or both. You don't want to be too slippery, so you want to test out these various options, but people find that can just make it a little easier to roll over or get out of bed. Another thing to consider, which is a little more traditional, is to time the medication so that you don't have that stiffness during the night. And that could mean taking a longer acting levodopa before bed. It could mean taking a levodopa when you wake up to go to the bathroom that first time, and those sort of issues to try to relieve the rolling over problem, which is a big problem for people.
So this is kind of related to that. How much longer does the extended release carbidopa levodopa last as opposed to the regular cinnamon?
That's a great question, and it's very variable. So really, I don't have a set answer. And there are two kinds of extended release, which is another complication. So there's the extended release that is no longer made brand anymore. It used to be called Cinemet CR, and now it's just available as carbidopa levodopa ER. And that medicine is notoriously unpredictable in its length of time. So some people find that it's really just as long as Cinemet, but some people find that it's, an hour or two longer. And the reason, I suspect, the reason it's no longer being manufactured is because it really wasn't a great CR. And so the newer CR is called Rytary, as I mentioned. And, you know, there really isn't one answer here. And especially since the response to Cinemet or carbidopa levodopa IR changes with time in an individual person. So the same person may get 5 hours or 6 hours from benefit from the medicine when they first start to take it. And as their disease progresses and there are fewer dopaminergic neurons in the brain, that amount of time can decrease to 2 hours in the same person. And so the response to Rytary will be similar, although it will be longer at each stage. So it's very, very hard to judge. My clinical experience, when you transition a person over from Cinemet to Rytary, you might expect an hour more from a particular dose, which could lead to quite a big benefit. Some people don't find that to be the case. It has to be experimented. You do have to have a lot of patience with yourself and with your doctor when you're making these kind of transitions, to really know how your body's dealing with those changes.
Okay, great. Can you talk a little bit, just briefly describe what cognitive behavioral therapy is and how it might help with sleep? I know it's
That's a
used for a
great
lot of
question.
different things.
Yes. So, you know, it isn't as formulaic as some other things like taking your Cinemet. So everyone kind of knows what that experience is like, and it involves a pill and water, and you swallow it, and everyone does the same thing. Their response might be different, but cognitive behavioral therapy might be a little more varied depending on your practitioner. But the general idea is that you evaluate the thoughts or the behaviors or the sensations or the biases that you have about sleep. So as anyone knows, whether they have Parkinson's or not, when you're not going to sleep, the act of not going to sleep and the feelings you have about not going to sleep make you not go to sleep. So it's a vicious cycle. And so breaking that vicious cycle is what cognitive behavioral therapy is going to do, and channeling the thoughts that are causing you not to go to sleep and morphing them into thoughts that will help you go to sleep. So it's really sort of an analysis of what behaviors have gotten you to this point and how to use them better, if that helps.
Yeah, I think so. Hopefully that answered the question of the folks that came in. It made sense to me for sure. Can you go back to melatonin for a second? And you talked about taking melatonin before you go to sleep. What about, and there's a corollary to this because a lot of people are talking about they wake up in the middle of the night and then they can't get back to sleep. So
Right.
is it okay to take melatonin in the middle of the night? What strategies can work in failing to fall back asleep once you're
Right.
up?
That secondary insomnia is the real problem for many people. And I would say it's probably more common in Parkinson's disease than primary insomnia. So the falling asleep at the start of the night versus falling asleep once you've woken up. Falling asleep once you've woken up seems to be more common and certainly very, very difficult and harder to treat because you are closer to when you want to be awake. So taking a medicine at 3 a.m. just doesn't sound like a good idea because you're gonna want to be awake in 5 hours, awake in a way that you're not feeling all groggy and hazy, maybe 5 hours later, 4 hours later. So it really, really limits you in terms of medication. I don't know the data on taking melatonin for that secondary insomnia. My gut is saying it's probably not the solution because what you're trying to do with melatonin is time it to your natural melatonin. And I'm just not sure what your melatonin levels are at 3 a.m. I don't know. I'm going to have to research that and get back to people. But it's definitely a harder problem to solve. The only medication solution that I'm aware of is using a long-acting medicine at the beginning of the night. So using like an Ambien CR at the beginning of the night, and that seems to be helpful to some people because it will help you not have that secondary insomnia. But taking a medicine so close to the morning can be really tricky.
Right. So
the other thing to consider, is that sometimes people think they need to go back to sleep and they don't. So I'll have a conversation with somebody, you know, they go to sleep at 10 and they're fine. Then they wake up at 3 and they can't go back to sleep. And they have already slept 5 hours. So it is also true that people as they age need less sleep. If you are not tired during the day, perhaps the concern and the worry that you're not going back to sleep at 3 a.m. is just feeding that worry, and you may be okay sleeping from 10 to 3. Consider that possibility, and perhaps shift your night so that don't go to sleep at 10. Maybe go to sleep at midnight and try to get, if that's very considered, being up at 3 a.m. is just does not jive with your day, perhaps try to shift your bedtime. That isn't necessarily going to be the solution for everyone. There may be plenty of people who do wake up at 3 in the morning and then are exhausted during the day because they haven't gotten back to sleep. So all those are possibilities, but in any particular individual, consider the possibility that when you wake up too early, it's because you are done with sleep for the night.
Okay. I'd get so much done if I was not tired, if I woke up at 3 in the morning the rest of the day, but I'm not that person either. So, you know, you got to experiment, right?
Exactly.
Yeah. So questions about melatonin reducing blood pressure and how big of a deal is this? Is it a blood pressure? Is there blood pressure change with melatonin?
It's not typically a problem. Everyone is different. So I would not say that the person who, you know, reported that is wrong. There could be certainly people who do have that side effect. And, you know, that's why we have to carefully weigh every medicine. Typically, we don't worry about that particular side effect for that particular medicine as we do other medications, for example. But in any particular person, anything's possible.
Okay. Okay. What are your thoughts on weighted blankets?
I think weighted blankets are a great idea. I've definitely had multiple patients introduce this concept to me. I was not aware of weighted blankets until a couple years ago when somebody said, you know, I read about this and I tried it and it's wonderful. It's obviously a very benign thing to try. And I can't think of a downside. So if it helps, then go for it.
Yeah. It's one
But
of
we
the
definitely
hot
hear,
holiday gifts for the year, apparently. So who knows?
yeah,
Yeah.
yeah,
Yeah.
absolutely.
Um, what does
Modafinil.
modafinil?
I saw that one
Modafinil.
come up.
Thank you. Yes.
What does it do? So it is a medicine that's approved for a sleep disorder called narcolepsy,
Mm,
which has nothing to do with Parkinson's, and it's a falling asleep without warning disorder. So it's a very rare disorder. You may have heard about it sort of anecdotally that this affects some people, that they're laughing or in the middle of a conversation and they fall asleep, and it's kind of funny and strange, but you know, very disabling to the person who has it. And modafinil is used to wake a person up. It actually works with a different neurotransmitter, a wakefulness neurotransmitter, in a similar way that Parkinson's is involved in dopamine. So this is a wakefulness neurotransmitter that modafinil acts on, and it has been considered for Parkinson's disease. There have been small clinical trials with a few people, so not enough to really stand behind it and say this is a great medicine for people with Parkinson's to maintain wakefulness, but it's definitely used by some practitioners off-label. So it's something to discuss with your physician. What you have to sort of settle on before you try modafinil is to decide whether that excessive daytime sleepiness or that fatigue isn't due to a poor sleep or to depression or to a medication. You don't want to be medicating a side effect of another medicine. You just want to get rid of that medicine. You don't want to be you don't want to be waking someone up because they're going to sleep because of depression. You want to be treating that depression. So you really do need to get a really good handle on why the fatigue is happening. But as I mentioned, there are plenty of people who who are absolutely convincing when they're describing their fatigue. It's this overwhelming sense of of being tired, and their sleep study's perfect, and they get their 8 hours, and they're not depressed, and there's nothing there that can explain their fatigue. Those are the kind of people that you want to consider a medicine to keep you awake. But you do want to go through all that algorithm to make sure that you're not missing a reason why you're so tired that can be corrected in and of itself.
For sure, for sure. And just to put a plug in for our new symptom tracker, or the new improved symptom tracker, I guess, I would imagine that being able to record and track that and be able to communicate that to your physician to figure these things out might be quite important.
Absolutely. I mean, everyone with Parkinson's on this webinar is aware of this. Like knowing when and where and why you have the symptoms is really half the battle, because it can be so confusing to everyone, including the person themselves. Why am I so tired now and not now? And what does it have to do with? And which medicine did I take? And trying to keep it all straight is super important. So very good point. Keeping track is really helpful.
Yeah. And we do have a new improved symptom tracker that can be downloaded. So that's out there for folks. And there are other ones not sponsored by APDA, but we do have this new symptom tracker. And I think, I thought you froze for a second there.
Oh,
so
I'm here.
You're good. You're here. So I have one more question that was typed in here, and it's about Ambien. And I think you talked a little bit about about being careful in the middle of the night, but Ambien being a fall risk, and does it kill brain cells? Because this person needs all their brain cells that they can have.
Right. So, there have been epidemiologic studies looking at cognition in people who have taken certain medications in the past. Acetylcholine blockers have been sort of in this category too. There's a different class of medicines. And so the bottom line is we don't know whether there's permanent damage from taking these medicines. We don't think so. But I wouldn't be absolutely 100% about anything. And that's the problem in medicine, because you end up eating your words. So you always want to make sure that you leave open the possibility that you are wrong. Being humble is, I think, the most important quality in somebody who's giving a talk like this, because everyone's different. And I just don't know every single person's response to every single medicine. So we really do have to be open-minded about this. In general, we do not think that a medicine like Ambien is going to contribute to permanent cognitive problems later. Having said that, as a side effect in a moment, it certainly can make you more groggy and more confused and have problems with walking, especially in somebody who already has cognitive problems. So again, part of that general warning that I gave, any medicine that's going to induce sleep, you do have to consider those side effects and make sure the timing of the medicine is right and the choice of the medicine is right.
Okay, great. Thank you. So this isn't a question from the audience, but there's a lot of different things that one can do if they're having trouble with sleep. If someone is having trouble with sleep, what do you think is the first thing they should try first?
Yeah.
What is that first step in, okay, I'm aware that I am having trouble sleeping. Now what?
Okay, so what I would do is work on your day and your night. So you want to make sure that you are exposed to light during the day, that you've gotten out, that you've gotten exercise, and that you're not sitting in a dark place, and that you're exposed to sunlight. So your day has to be a day. Mm-hmm. And then when it becomes, and you want to make sure that you do those activities, then you have a break and you give yourself a chance to wind down. That's when the body's starting to build up the melatonin at the end of the day. And then you want to make sure that your night is calm, that your bedroom is a calm place with the right temperature and the right amount of noise, preferably no noise. Or some people do need sort of a little buzz and have a noise machine. And so you want to come up with a nice environment for yourself for the night. And you want to make sure there's no television in the room or on. And you want to make sure that you're not looking at screens right before bed. And you want to do some calming activities before bed. And then you want to ease into sleep. So I think setting that up, the day and the night, is the first thing to do. That's what I would say.
Great. Thank you. I think that's a good way to conclude this talk about sleep. And then you start to look at the other things.
And then
that
you
you
start to look
tapped
at
on.
the other things.
Right, right. So thank you all for joining us very, very much. And thank you, Dr. Gilbert, for such an informative talk on this great subject that I hear a lot about when I'm on support group calls and stuff, because sleep is so important in how we feel. So appreciate all your insights in that. There was a question about the symptom tracker. And I will be doing a post-event email to everybody who signed up for the event. I will give you a link to where this is posted on our YouTube channel, as well as a link to the slides so you can review those later. And a link to the symptom tracker. It also can be found on our website. And if you look in the chat, it's also there as well. So that will all be there for you. We are going to take a break for the rest of December in educational programming. I believe it's a break on the national level and on the local level from these virtual educational programs. But we do have all the great virtual exercise programs still going on, so you can keep active during this holiday season. We will bring you more virtual programming in January. So stay tuned to the news you can use email that we send weekly that will tell you about everything that's coming up, as well as our website. We're going to have a great Passport to Research series that's going to talk to local researchers and do interviews, and we're having that coming up in January, and the state control series will continue. So stay tuned for that. When you exit, there will be a link to a survey. So please let us know what you think about this programming. Give us suggestions on how we can do things better, different subjects that you might like to hear about, because we will be doing more of these. So thank you, everyone. Dr. Gilbert, do you have any final parting words for our audience?
If you have any additional questions about sleep or otherwise, you can email me at rgilbert@apdaparkinson.org. I'm happy to hear your questions and try to answer them.
Yeah, thank you so much. It's a great resource. And if you need any resources from APDA, please feel free to call us on our local number, 206-695-2905, or visit us on our website, apdaparkinson.org. Or if you're throughout the country, we have a 1-800 number that I don't know off the top of my head.
1-800-223-2732.
Excellent. All right. Well, I hope you all have a nice, relaxing, restful, strange holiday season that this is, but enjoy the rest of your winter. We will see you in the new year. And thank you so much, Dr. Gilbert, for all of your time and your insights.
My pleasure.
All
Thanks,
right.
everyone.
Goodbye. Have a lovely weekend, everyone. Bye-bye.